Complicated and persistent cases of Lyme borreliosis pose a serious challenge for global and national health organizations. There are thousands of patients with chronic Lyme disease across the globe, perhaps hundreds of thousands, perhaps millions, and many of these patients are very seriously ill. Given that simple fact, it would seem on the surface that the WHO, the UN, and all the national health services have a simple obligation to do whatever it takes within the limits of resources to provide biological medical care to as many chronic Lyme patients as possible. But as with ME/CFS, mitochondrial disorders, fibromyalgia, and a long list of other contentious conditions, the medical community has not yet reached a consensus about the biological science that explains chronic Lyme. As with all contentious conditions, many physicians, researchers, and policymakers believe evidence proving a scientific basis for chronic Lyme is lacking, and that it's lacking because the condition is actually caused by psychosocial distress. The stakes in this debate are extraordinarily high, and this fact is often not appreciated by policymakers. If those who reject the biological research on chronic Lyme disease are correct, then it's inappropriate to provide these patients with biological medical care. Doing so would be potentially harmful and wasteful of valuable resources, but there is debate on this point. There is substantial peer-reviewed scientific research that suggests it's a serious and sometimes grave mistake to deny medical care to patients with chronic Lyme. If that research is correct, then adopting a policy that denies medical care consigns thousands, perhaps millions, of medically ill patients to years of untreated suffering and bodily harm that might well have been avoided. This kind of outcome is one the UN, the WHO, and all the national health services are pledged to avoid. Global health organizations have neither the mission nor the resources to undertake research that can resolve the scientific dispute about chronic Lyme, and yet, in the midst of this heated debate, decisions must be made. Policies for management of the disease must be developed and implemented. In the absence of scientific consensus about the biological basis for chronic Lyme disease, what principles should guide the decisions of policymakers instead? The central point I want to make today is that when organizations face opposing views about the biological basis for a condition, and this comes up a lot, they can reach successful policy decisions only on the basis of clear and careful ethical reasoning. The process must begin with this two-part ethical question. Given the organization's beneficent mission, and given the current state of uncertainty about the condition, 1. What actions are policymakers obligated to undertake? And 2. What actions are they obligated to avoid? When it comes to the first kind of obligation, the central challenge is this. Do organizations have a duty to actively ensure that chronic Lyme disease is always managed with biological medical care rather than strictly psychosocial care? Some scientific researchers say yes, but others say no. Because this dispute remains unresolved, ethically speaking, obligations of this first kind remain unclear for health organizations. When it comes to the second kind of obligation, however, answers are readily available because there are some actions that organizations are ethically obligated to avoid. The WHO, the UN, and all the national health services have an obligation not to knowingly implement policies that obstruct access to medical care for any patient group who might have a serious need for it. Ethically speaking, this is uncontroversial, and it's a fact with profound implications for Lyme policy. Given that there is a significant possibility that chronic Lyme patients are in need of medical care, clarity on this point makes it clear that organizations have an obligation not to implement any policy that would obstruct patients' access to medical care for chronic Lyme disease. Current diagnostic codes do obstruct access to medical care for the chronic Lyme diseases that are now ignored. And that means that given the obligations of the WHO and the UN, these codes must be revised. While ethical reasoning does not demand that care for chronic Lyme must always be directed down the biological track, it does demand that coding must make it possible for patients to access biological medical care. While providers might be afforded some freedom in their choices about management, coding must be developed in a way that always makes it possible for patients and providers to choose the biological track. At this time, faced with the task of developing new criteria and codes, policymakers struggle to pick a side in the debate about the biological basis for chronic Lyme. I'm suggesting that approach is misguided, that organizations should develop Lyme disease policies without taking sides on the unresolved biological issue. These decisions must be based on clarity about the ethical obligations that should guide policymaking in the absence of scientific consensus, and those obligations are clear enough to dictate policy. It is unethical for organizations to implement or support diagnostic coding that obstructs access to medical care for patients with chronic Lyme disease. Every human being has a right to health. And the WHO, the UN, and all the national health services must proactively protect that right in the context of scientific uncertainty. It is possible that the thousands of patients with chronic Lyme disease are suffering the harms of a biological condition that requires medical care. Even those who stand on the side of psychosocial care do acknowledge this possibility as a matter of scientific fact, and the possibility is all it takes to clarify the ethical course of action. No organization, in good conscience and in keeping with a medically beneficent mission, can adopt or support any approach to chronic Lyme disease that obstructs patients' access to biological medical care. To do so would be to risk consigning thousands of medically ill patients to lives of unnecessary medical suffering and harm. That is a risk that cannot be ethically justified. Thanks very much.